Welcome back. Clinical uses of non-invasive positive pressure ventilation. In inpatient settings, in the acute situation, in the floor or emergency room, acute pulmonary edema. So if you're having patient with acute pulmonary edema, use CPAP. And of course, this patient hypoxia, so I would recommend you use 100% FiO2 and 15 centimeter H2O to start with and treat the underlying condition. Now, let's say you told the nurse, hey, use BIPAP, let's say 15/5 with this 100% FiO2. Of course, the nurse may or respiratory therapist will take it from you, but remember, this is the number that you want really to be higher than this. So if you want to order BiPAP, that's good. That's okay. But make sure the EPAP value is high enough to help the patient. Now, some pulmonary edema patient will have respiratory acidosis. Then you can use 10/20, or if you want to use it 25/15. That's okay. But for pulmonary edema, this is what you think about, and put the patient right away on that. If the patient is huffing and puffing and in respiratory distress, just put them on that. Give them the other treatment of pulmonary edema. COPD exacerbation, of course, BiPAP or BiPAP. We don't need to think. We explained that thoroughly on the previous episodes why BiPAP is the best in COPD exacerbation. Again, you need to provide a FiO2. Remember, COPD exacerbation, their oxygenation is okay, so you don't need to give very high of FiO2 unless they're having pneumonia, along with that causing a lot of hypoxia. So the FiO2 tailored to the amount of hypoxia. And then if they have respiratory acidosis, you need to give them a good delta P. Let's say you start 15/5 or 16/6 or 12/6, and make sure in all cases here, once you diurese them, once they're breathing better, feeling better, you can wean them of that. Will come to the weaning soon. And make sure you monitor them and repeat ABG in the next hour, 1 to 2 hours. So you need to monitor, make sure they're not getting worse, that they need to be intubated. So these are the main. The other one which is debatable is acute asthma exacerbation. Let me make it simple and clear. If the patient having severe exacerbation and treatment not helping with steroids, breathing treatment, magnesium sulfate, and you think the patient will need to be intubated, it doesn't hurt if you try it for 1 to 2 hours on BiPAP or BiPAP. Do it, monitor them closely, follow up ABG, and if there is any signs of worsening, intubate. If they are improving, great, that's what we want. But don't go more than 1 to 2 hours. Well, here I can use the BiPAP for hours and days in COPD sometimes. And in pulmonary edema, if it's gonna work, it works in few hours, as long as you're treating the underlying problems properly. So these are the main acute indications for that. Of course, any other acute hypoxic respiratory failure you can use with. Now, let's say hypoxia from pneumonia, PE. If we're talking about only hypoxia, then we think about the CPAP. If we're thinking of ventilation, we have to think about the BiPAP. Ventilation and hypoxia, BiPAP. Remember that. Now, if the patient is refusing the mask, this is a big mask, right? Or claustrophobic and cannot tolerate that. Or non-cooperative. He is not keeping things and the mask keep leaking. Then this is the role of high flow nasal cannula, or the other name vapotherm, the brand name. Again, if I'm thinking about non-invasive ventilation, think about BiPAP and CPAP first, unless the patient refusing those modes, or as I said, refusing the mask, claustrophobic and refusing to wear it and keep taking off, non-cooperative, that's the thing, then we can use. I don't think about high flow nasal cannula first, and I don't offer it first when I feel about non-invasive ventilation, but it's an option. And this is mainly an option for hypoxia. Not much about ventilation, although some saying we can still use it for ventilation and help with hypercapnia and COPD. Even the manufacturer mentioned that. But take it from me, when you think about COPD or everything, think about a non-invasive, think about these first, and then this after that. So these are the acute indications. The chronic indications for that, we mentioned them, is chronic respiratory failure in COPD that fail to respond. They can use BIPAP, and if they fail to respond, BIPAP can use trilogy machine. Obstructive sleep apnea, obesity, hyperventilation syndrome, neuromuscular disorder. Mainly we talk about muscular dystrophies, motor neuron disease, and mainly pulmonologists managing these cases. Thanks for watching this video. Please subscribe to our channel and activate the notification bell so you get to see the videos as soon as they are released. Glad to have you on board.